Our next panel is Stakeholder Engagement in MCBK, and that panel will be moderated by Josh Rubin. Josh is Program Officer for Learning Health Initiatives at the University of Michigan Department of Learning Health Sciences and is very active in MCBK in the planning of this meeting and a number of the work groups. So Josh, I'll turn it over to you to introduce the panelists.
Thank you, Rachel, and thank you to my panelists, Michael Fitz and Sally Oken. I am very excited to be moderating the session on stakeholder engagement in the MCBK movement. Before introducing the exceptional panelists, I just wanted to actually share a few different quotes to sort of frame our thinking on why engaging all stakeholders in this movement is very important. First off, in addition to my role at the University of Michigan, and actually my first introduction to the learning health system concept came my role as executive director of a philanthropic foundation called the Joseph H. Cantor Family Foundation. And that was founded by a patient activist. And the vision of that foundation is that every decision affecting health should be informed by actionable knowledge of what works best. And that's important that, this actionable knowledge inform every decision, not just decisions by clinicians or decisions just by administrators, but decisions by every single stakeholder. And that requires every single stakeholder to have access to the knowledge in a form that's useful to them. And that requires bringing everyone into the movement. Two quotes from a while back I wanted to start with. One is by Martin Luther King Jr. Of all forms of inequality, injustice in health is the most shocking and inhuman. And that was from 1966. And a year before that, we have a quote from Senator Lister Hill that's on the side of the, inscribed on the wall of the Lister Hill Auditorium at the U.S. National Library of Medicine, where the MCBK movement itself took a very big early step. And that quote is, "We must develop a communication system so that the miraculous triumphs of modern science can be taken from the laboratory and transmitted to all in need." I think there's absolutely a relationship between these quotes that the only way, and they're from over half a century ago, but one essential component of starting to make our health system more just, more equitable, is ensuring equitable access to the knowledge that informs decisions that affects lives. This has been baked into the fabric of learning health systems and beyond. As Chuck mentioned earlier, in 2012, a whole bunch of different stakeholders came together to come up with core values for learning health systems. And some of these values include that it'll be person-focused, that it will be inclusive, that every individual and organization committed to improving health of individuals, communities, and diverse populations is going to be invited to participate, and that it's going to be accessible, and that all benefit from the public good derived from the learning health systems. Therefore, learning health systems should be available and deliver value to all, encouraging and incentivizing broad, sustained participation. And that idea has made its way very much into the MCBK movement and the manifesto. Indeed, if you look at part of the vision of in the manifesto that we've been speaking about throughout this meeting, one of the lines is equitably and efficiently serving learning needs of all participants as well as the public good. And doing this is something that we're dedicated to because it's going to significantly reduce health disparities and bring everybody in. Knowledge has the potential to improve healthcare, the health of individuals, and the health of populations. Every decision affecting health has to be informed by the best available knowledge. And that's why, for moral and ethical reasons, it's imperative that each and every member of society have access to what is known at the time they are making a health-related choice. So with that said, I'm going to be introducing our panelists that have done an awful lot really around this whole idea of democratizing MCBK. The way it works, I'll introduce the first panelist. He'll speak, then we'll take some questions, then we'll do the second panelist. She'll speak, and then we'll have some broad questions. So please submit your questions as this is going. Our first panelist is going to be Michael Fitz, who's a native of Huntsville, Alabama, an assistant professor, an assistant dean for user access and diversity at the University of Alabama at Birmingham and the UAB libraries. In 2001, he became the first African-American faculty member of the Lister Hill Library of Health Sciences, and in 2015 became both the first African-American assistant director and later moving up to the rank of assistant dean. Throughout the majority of his career, Michael's been active in serving those that are underrepresented, but he also wears other hats. In addition to his 20-plus year career with UAB, Michael's become an advocate and a cooperative example of humanitarianism. His personal passion includes educating individuals, including youngest onset and people of color, on how to successfully live with Parkinson's disease, a condition that Mr. Fitz was diagnosed with in 2011 at the age of 38. So with that said, I'd like to introduce Michael Fitz and hear from him, wearing these different hats as a patient activist, in his role at UAB and beyond about this movement and bringing stakeholders into it.
Good morning, good afternoon, everybody. I appreciate those kind words, Josh. Thank you so much. Just wanted to thank everybody in advance, especially Rachel and her team, for inviting me to come and speak at this exciting event. So I'm going to go ahead and jump in if you don't mind. So we're here to talk about stakeholder engagement, and I'm really going to talk from a patient perspective, just to kind of like give that particular aspect of things. So jumping right in, one of the things that really kind of like shook up my life, no pun intended, was the news, the diagnosis that I have Parkinson's. So obviously that was unexpected news that is going to go on to forever change my life. You see that little shake with the Parkinson there. I had to put that in the slide. So I wanted to talk a little bit about my original diagnosis and the experience. My initial experience was the physician came in. He said, "You have Parkinson's." And he said it like that. And so there's this deathly silence in the room. There's like crickets chirping, all that kind of good stuff. And so the next question he asked me was, "Do you have any questions?" So if you can imagine putting yourself in my particular situation, African-American male, 30-something, 38 to be exact. And, I just received the devastating news that I had Parkinson's, which is an incurable neurological disorder. I had no questions. In fact, I had no words. I really did not know what to say. And the way that that experience went was just kind of mortifying. It really was. So, we both sat in the room, looking at each other, basically, trying to gain my composure. So my next statement to him is I wanted to have a second opinion, which he said, "Well, you can have a second opinion if you want, but they're going to agree with me." So once again, I'm at a loss for words. I was mortified. I don't think that's exactly the most politically correct or a good bedside manner to, deal with somebody that received that devastating news. So me being a logical person, I wanted to kind of like rule out some things. So one of the things that I asked him is I wanted to have an MRI. His response to my request for an MRI was like, "Absolutely not. It's a waste of time. It's a waste of money. You cannot have an MRI." Well, needless to say, I fired him as my physician. I had no other use for him. So I kind of like went home, tried to gather my thoughts, my feelings, my emotions. As you can imagine, it was pretty tough. So just like I said I was going to do, I did get a second opinion. That second opinion, well, first of all, she said that she agreed with the initial diagnosis, which I didn't necessarily have a problem with that because of the way that she managed herself and carried on the conversation. And she really acknowledged the fact to me that she understood that it was really a lot to deal with, a lot to process. And just her kindness and that, really made a tremendous difference in receiving that devastating news. So obviously, she still gave me, although this was the second time that I've heard this, mind you, she still gave me time to kind of like gather myself. She acknowledged that fact and gave me an opportunity to ask her questions. And I did have some questions for her. One of the most important things that I received as a patient in this particular instance was she offered positivity and hope. And that's something that we really, really need in healthcare, because a lot of times we get these diagnoses and frankly, sometimes it kind of comes across as a death sentence or a death sentence like, news, and it's devastating. So the fact that she was positive and, gave me hope was just really a wonderful thing. So once again, I wanted to have an MRI done. She said, absolutely, I can understand why you would want to have that done. You want to rule some things out. Now, at the time, I did not really know, although the first neurologist so rudely told me that an MRI is not a method to determine whether somebody has Parkinson's or not, which I'm not a physician. I mean, I didn't know that. And I think his response was a little abrupt and, premature, although in that instance, he was correct. It was just a manner in which he proceeded with it. So I do appreciate the second diagnosis I got, and she encouraged me and had the diagnosis for the MRI, had it done, and it came back normal. Although later on we did find out that in a future exam that I actually have a small tumor on my brain too, which they would not have known had they not have done the MRI. So patient engagement versus advocacy. Patient engagement is a simply defined term, which is a combination of ability and expertise to improve the patient's experience and encourage them to take positive action, which is what a lot of this topic is about, the MCBK movement, and really wanted to give people the ability to improve their situation. So patient advocacy, which I fall more under, is defined as an organization, a group, or individual that shares its concerns for healthcare, which obviously that's something that's extremely important, especially nowadays. I think that people are taking more of an active role as far as like making sure that they get the information that they need and doing some of their own research for their own healthcare, because nobody's necessarily going to care for you like you would care for yourself. As wonderful as our physicians are, we do have to take an active role as a patient in order to move forward and to better our health. So patient engagement, why a priority? Well, I kind of look at it in two different terms, culture and communication. So the culture says that there's a mistrust of the medical community, and that's been around for a long time, especially in underserved populations like individuals of color, especially the Latinx community, LGBTQ community. So that's just basically, it is what it is. Also, a part of the culture was an overall belief of poor treatment of patients and family members. Oftentimes in the past, and I think it still happens some, although we know better. When you know better, you do better. Sometimes I think there's an assumption, or maybe there's not an assumption. Maybe somebody is not necessarily as well educated or does not necessarily speak as well as somebody with a college degree. And sometimes because there's that, people are talked down to. But I can even give you an experience. I'm a college degreed librarian, medical librarian, and people have talked to me, like I didn't know what I was talking about, or, I can't even believe that you would ask that. Case in point, me asking for the MRI. So also a part of the culture is the fear of mistreatment via research and clinical trials. This is huge. Well, one of the things that I found out in my experience is that I was really, really being encouraged to take part in research and clinical trials. But because of things that have happened in historical times, most notably the Tuskegee syphilis incident, there's like a fear of research trials and thinking that, that they're going to try to give us something intentionally. They're not going to treat us well. They're, going to have us in unusual pain and not give us treatment, that kind of thing. So as far as communication is concerned, a reassurance of participation within counsel. We want to make sure that we're participating in all the procedures that are going on and making sure that we're taking an active role in that. We want to share positive experiences as a patient. That's extremely important because I think oftentimes other patients will be more apt to listen and take more credit from somebody that's already another patient, because it's kind of like a kinship, a brotherhood, a sisterhood, that kind of thing. And then also the interject the success and advancement of research in IRB. And we all know that IRB is extremely important. sometimes it's a challenge to get things approved by the RRB. I'm sure nobody's had that issue before, but it's extremely important. And so I want to talk a little bit about my expectations as a patient advocate. And I'm really talking about this basically about what I expect and then what I'm also expecting out of myself. And I'm going to talk about it in two different ways. And number one is a seat at the table. Speak out. It's extremely important as a patient advocate that you let your feelings, your experiences be known, especially when there's other people involved and they might not have that same voice as you necessarily. And it helps encourage people and give them the strength that they need and the courage that they need in order to speak out more. So you have to make the connection with your colleagues. You even make the connection with your researchers, your physicians, because a big part of it is really, it's a team and you have to be a part of that team and you have to think about your healthcare in that team mannerism. Lead by example, show yourself that you're going to be a participant and advocate, that you're going to speak out, that you're going to even talk about those subjects that somebody else might be uncomfortable speaking about, but because you had the courage to do it, they'll do it. Like I said, be included in clinical trials. That's a big thing. I find out a lot of times, and it's even a challenge today when I tell people that I'm involved in clinical trials. They're like, well, why would you do that? Aren't you afraid they're going to do something to you, or they're going to do this and they're going to do that? And so myself as a patient advocate, I have to lend a voice and give that courage and give them the ins and outs of that experience. Everybody's going to have a different experience, but I think that if you can kind of encourage people and let them know and be honest with them about what you've experienced, I think that'll give them a little bit more courage. Patient education as far as communication. I mean, what else needs to be said? I think that's self-explanatory. You have to educate yourself. And then also a part of the team, the researchers are going to have to kind of break down the language and talk to the patients in a way that they can understand. For researchers, always start with the truth. You want to be honest. And sometimes that honesty is brutally honest. Be straightforward even about the clinical trials and some of the side effects that might take place and things that you might experience. You don't necessarily experience everything, but the truth always is a good way to start. Also answer my questions. Sometimes the questions might be odd, they might be a little uncomfortable, whatever, but in order to give comfort to a patient that's asking those things, it's better that you're straightforward and just answer them to the best of your ability. Oh, this is a huge one. Report back the findings. I think a lot of times, and I've even experienced this when I've gone to clinical trials and I'm sitting up waiting, well, I wonder what's going on. And then I just never hear anything, which is a good way to get somebody not to participate in clinical trials. Let me just tell you that by personal experience. So what makes my background somewhat unique for my advocacy? My education and career. I have a master's in library and information science. By trade, I'm a health sciences librarian. And then I also work for one of the leaders in Parkinson's research, which is the University of Alabama in Birmingham. I also have real life experience. Obviously, I'm an individual living with Parkinson's. I've been featured in the resource Parkinson's 360, Real Talk for Patients and Families. And this is available through the Michael J. Fox Foundation. It can be found on his page, and you can order a hard copy of it. And there's also video. If you do a search in YouTube and put in Parkinson's 360, there's different profiles that'll come up, and there's a gamut of individuals from a diverse community that kind of talk about their experiences, and I'm one of those people that are featured in that. And then I'm also a research advocate for the Parkinson's Foundation, and I'm a card-carrying member. Literally. So I also wanted to talk a little bit about a couple of the other patient advocacy groups that I'm a part of. One of them is the Legacy of Hope, which is formerly the Alabama Organ Center. And specifically, I'm a part of the African American Task Force. And so the mission of the group is, the task force is to support the overall mission of the Legacy of Hope by providing education, community outreach, and primarily African American communities by dispelling the myths related to organ, eye, and tissue donation and increase the number of registered African-American organ donors in the state of Alabama. This is extremely important because for some reason there's all of these urban myths and legends that go on. Like if you mark it on your driver's license that you want to be an organ donor, that if you're in a car accident or whatever, or you're in the hospital, they're not going to save your life. They're not going to do everything to save your life. Or they might put you in a bathtub full of ice and cut out your organs. That kind of thing is kind of crazy. And, you know, I'm making light of it. But really, there's a lot of individuals out there that think that. So that's one of the missions of this particular institute, is to let people know and to educate them about the organ donation process. Another one that I'm particularly proud of, and I helped to start this at the University of Alabama in Birmingham, and it's called Hopeful Healing. And it's a support group for coping with chronic illnesses. And basically, it's a group of individuals, specifically staff, faculty from the University of Alabama in Birmingham. And we get together and talk about how we're dealing with our chronic illness and how our work affects it. And so why are support groups important? So coping with chronic illnesses, so many people nowadays have chronic illnesses, which is why once this COVID-19 crisis is, so many people have pre-existing conditions. So this is one of the avenues that we have to kind of like talk about this. And it really provides a safe space. There's often times where you're wrestling with whether you want or not, whether you want to disclose your chronic illness to your employer. You know, a lot of people like wrestle with that. So this is kind of like a safe place, and we can give each other advice and our experiences of how we've dealt with that. Kindred spirits, same thing, goes along the same lines that I've been talking about. And empathy, somebody that can actually understand and put themselves in the situation that you're in, that will just really, really understand and not just necessarily pat you on the back and like, or pat you on the head rather, and patronize you. And it also leads to a sense of belonging because people like really understand where you're coming from. And so finally, I want to talk about the Michael J. Fox Foundation for Parkinson's Research, and I serve on the Patient Council. So what does the council do? It serves really to give and receive input from not only the patients, but the researchers, and they get us together in one room, and we have these conversations together, which is extremely important. We advise the foundation and the PD community at large about our findings, our experiences, and that sort of thing. We promote a sense of extended family, which is extremely important. As you know, and not just Parkinson's disease, but any kind of healthcare condition that you might be dealing with, it's really, really hard sometimes, and even your natural born family might not necessarily understand. But when you have these individuals as your extended family, even when you don't feel like you have anybody to talk to, they're just a phone call or an email away. So that's exactly why that's important. And it really provides an atmosphere of non-judgmental forum to share your feelings and the challenges that you have. And here's a couple of individuals that are on the Patient Council, including myself. And I don't know if anybody recognizes on the far right end of the picture, that's Jimmy Choi. He is an American ninja, actually, and has been on the show a couple of times and has highlighted his journey with Parkinson's disease. He's really a great guy, Jimmy. And so Parkinson's Foundation research advocates influence Parkinson's funding. This is what this slide talks about. And I was fortunate enough to be a consumer reviewer back in 2019, which seems like it was so far and long ago because of the way that this year has started. But it's extremely important to have like consumers and patients on these groups, because I think oftentimes maybe as researchers, because we have the scientific knowledge or whatever, we kind of forget and put aside the patient perspective. So this is one way that we've been able to do this and bring back that perspective and make sure that we're all working together as a team. And so consumer advocates and scientists have worked together in this unique partnership since 1997. And so I'm thinking I'm probably a little pressed for time, so I'm not going to show this video. But once again, if you go to YouTube and do a search on Parkinson's 360, you can find out like Jimmy Choi and my story and a couple of other individuals. And I hope that you'll be able to find something that you'll be able to relate to and that you'll enjoy. So here is my contact information. If anybody ever wants to contact me, if you have any further questions, I'll be happy to follow up with you. And so just thank you everybody for the invitation once again. And are there any questions?
Thank you, Michael, for that excellent and passionate presentation. I'm also helping with our Twitter account. So I actually found something on the Michael J. Fox site quickly about Parkinson's 360 and posted a link that mentions you right at the beginning. And I think it looks like it has a video of you, Michael. So
absolutely.
People following our Twitter feed or following the hashtag MobilizeCBK will can see that posted. So a couple of questions have come in from Michael, and let me try to balance going to my email and reading them while talking. I'm still getting used to this approach. So I see quite a few questions are now coming in. But let me Michael, the relevance of knowledge to a patient is based on evidence generated in trials. What would you see benefit in some CBK that can represent the diversity of research subjects?
Could you repeat that one more time? I'm sorry.
Sure. The relevance of knowledge to a patient is based on the evidence generated in trials. Would you see benefit in some computable biomedical knowledge that can represent the diversity of the research subjects?
I definitely see that as a benefit. It's going to be extremely important. Now, one of the things that I'll probably mention briefly is the whole experience about access, and the consumer access is extremely important. But part of that too, the access of the information that's out there has to be reachable for individuals, and it has to be on a level where they can understand it. I think that health literacy is like a huge part of that. Oftentimes, some of the literature that's out there is hard to understand. So I think the researchers in the community could really like come together and talk about the importance of the MCBK and how we could work together in order to benefit a more diverse pool.
Excellent. I'll read you a couple of just nice comments. One is such a great presentation, especially considering the spotlight effect of data we have, large underrepresented populations and data we use for our clinical decision support. Great thoughts on inclusive care and data. Thanks. Another really nice comment. Thanks so much for sharing your story, Michael. It gives others a voice as well and helped us think, us patients and not just researchers, as you pointed out. I have actually quite a few other questions for Michael, but seeing that we're at the halfway point, I want to let our next panelist, Sally Oken, speak, and then after she speaks, I will take the questions for Michael and Sally, and the ones that come in for Sally, and raise both of them. So, without further ado, I want to introduce Sally Oken. Sally previously served as the Vice President of Policy and Ethics at Patients Like Me for 12 years. And by the way, under Sally's leadership, Patients Like Me was the first organization to formally endorse the consensus core values for learning health systems. Sally led the development of Patients Like Me's drug safety platform, patient ontology, government and regulatory affairs, and the Ethics Compliance Advisory Board. Oken, who's a registered nurse by training, has been a leader in advancing the science and use of patient-generated real-world data into care, research, and policy for over 4 decades. She received her graduate degree from the Heller School at Brandeis University and was National Library Informatics Fellow in 2010. She's a volunteer with the Medical Reserve Corps of Virginia. She's been passionate about learning health systems and patient empowerment for well over a decade, and thank her for her work that she's been doing and continues to do to advance this movement. And without further ado, I want to turn things over to Sally Oken, who's going to talk about democratizing the computable biomedical knowledge.
Well, thank you very much, Josh, and thank you to the planners of the meeting for inviting me. And it's always an honor to follow the story of a patient. And so I appreciate Michael's comments so much. And I'd like the audience to think for a moment, imagine Michael's experience and his clinician's experience, for that matter, if they could have partnered with really relevant and time-sensitive information that might have been available right there for them at the point of care. It could have saved not only some time for Michael, but also might have saved that relationship with that physician in some ways, and helping that physician better understand what the patient's needs might be. So with no further ado, let me move on. I am interested in having this group feel challenged today, not only by Michael's comments, but I think in more broad terms, to think about when we talk about the inclusion of stakeholders, we're really starting to break down that word and understand what exactly does that mean and how can we ensure democratization of this incredible knowledge that we're going to be gathering and making more available. So my topics for discussion today are going to be broken down into 3 areas. First is a miracle. We're going to talk a little bit about that and whether or not we're just waiting for a miracle. The second is really posing 2 questions to this community and also challenge. Think about whether or not these are things from a patient perspective, from the public perspective, we can actually start to dismantle, again, as stakeholders, what does it mean for the MCBK community to include the public and the patient in their involvement in advancing this knowledge that we're trying to move from 17 years to 17 seconds. And lastly, I'm going to introduce 6-person or patient-informed principles that actually came out of work that we did with our ethics advisory board at Patients Like Me throughout a good part of the end of 2018 and into 2019. And they were created with the notion that we needed to, as a company, start thinking about making a commitment to members about their data in the digital age. So, as we've been playing around with those since leaving Patients Like Me in the Ethics Advisory Board that I worked with closely on that, many of us remain colleagues and friends, have been playing around with ways of making these more broadly accessible, but also more broadly relevant to any particular enterprise or engagement opportunity where digitized knowledge is something that's going to be the output, and that the end user, the public and patient, are going to try to make use of it. So bear with me with those as we go through them. I think the relevance to the CBK community is quite there, but it's now a matter of starting to play with them and see if we can make them actionable and potential to be part of the implementation ideas that might come out of the meeting today. But let's move on to the miracle. Most people today are engaged in some sort of digitized knowledge. We deal with it every day in our phones and in different ways that we engage with the personal assistants we have in our homes. Yet I would be surprised to encounter many people in the public or patients themselves who actually are aware of the mobilized computable biomedical knowledge movement, right? So at some point, we have to acknowledge that we can't wait for a miracle to occur, that we need to get more explicit about what it means to move from this incredible body of knowledge and people who are behind this movement to a point where it does get more broadly democratized across not only the public, but patients specifically, and in their encounters, especially at the point of care where decisions need to get made. So really mobilizing this information into something that's implementable every day as part of the experience that we have with digitized information. So that's not only a challenge, I think, for this whole group and the movement, but also what does need to occur in that second step, for example, here, and really begin to think about how do we move forward and not have to depend on a miracle to occur, which I don't think we want to do. So with that in mind, I have a couple of questions and some associated challenges for this community to contemplate today and even going forward. We need to consider whether or not we actually have a value proposition for patients and the public to feel that they actually might have direct value from computable biomedical knowledge. Have we intentionally thought about that? Have we considered what does a value proposition look like if the end user of these knowledge objects is going to be a patient or the public at large? So the challenge here is, if yes, well, then let's get it out there and start sharing it. I have a feeling we need to do some work on it. So if no, let's get patients and the public involved in creating one. So someone like Michael's experience, for example, bringing that to bear on the kind of knowledge one would need to have accessible and available and actionable at the time that they need it. And I think the manifesto speaks to that quite clearly. So that's a challenge to us. We need to think about how we'd like to create that value proposition informed by the public, informed by patients in ways that ultimately translates this into something that's actionable and usable. And then the second question and challenge, and I think, again, because we are all so immersed in COVID-19, the amount of research that is underway currently, and that actually is even lots of it behind us already, and lots of it still ahead of us in diagnostics and treatments and vaccine, does that provide this community an opportunity to advance trustworthy information versus the ubiquitous misinformation that oftentimes people are getting exposed to on a regular basis? And it brought to mind something I think that Michael raised too, is really starting to think about breaking through misinformation, finding ways of having this kind of knowledge accessible so that we can have that rise up versus the misinformation, which is unfortunately the kinds of stuff that people are oftentimes being exposed to, and ultimately causes the problems with culture and communication, that people don't know what to trust. And so they look to whatever might be in their sphere to say, well, okay, if my friend or my family member thought this was worthy of their trust, then I might pay attention to it too. Could be very wrong information. So again, if we don't haven't really thought about what this opportunity is to break through and really start to provide trustworthy information based on all of this work that's being done in these three areas of diagnostic, treatments, and vaccines, then let's get going. Let's figure out something that maybe we can do. And frankly, I think there were a few things that were presented yesterday that pose opportunities, but I think most of those pose the opportunities to the clinical and research communities versus necessarily thinking about how would it be applicable to the public and to the patients. So, all right, so I'm going to make a shift here and talk a little bit about the patient-informed principles that I mentioned before. And keep in mind, these were developed as part of an undertaking that our Ethics Advisory Board at Patients Like Me took on to really develop socially responsible principles that could guide stewards of personal and biomedical data. And at that time, certainly at Patients Like Me, and continues to today, be stewards of that type of data. But we recognize that these were principles that should actually be more broadly shared because of the number of people and entities that today are stewards of data. Over a period of about 3 months, we iterated on these principles. We shared them across a variety of different people. We vetted them. We ultimately prioritized them with over 700 patients who were members of Patients Like Me, with our employees during listening sessions, and more specifically and more concretely with the members of the Patients Like Me team of advisors, which are cohorts that come together every year. There's about a total of 100 people in that group over the course of years that have begun to be really voices of experience that really do advise the company on a variety of different things. So we spent a lot of time in conference calls, listening sessions. We conducted surveys in order to find ways of prioritizing these. We started with 8, we got them down to 6, and I think there'll be things I think that will have relevance to this community. And I really would like to imagine that they are a foundation that we can build on, but that they actually sit nicely on the FAIR principles. And so I think we can bring those kinds of things together. I think the piece here that's so unique is that these have been informed and developed and prioritized by patients themselves, and in many ways, the public as well. So the first one, and what always surprised me as we were doing the vetting process and the prioritization, is this principle came up first every time. It's incredible to me, after all these years of working with patients and their families, that the idea of learning something on a regular basis is so very important to them. So any learning health system obviously has got to commit to this. But I think when you're thinking about the MCBK community, thinking about this as a priority is really important. Continuous and shared learning. Now, that's going to be different depending on the stakeholder you're sharing this with. But I think, again, if we believe in a continuously learning network, it means that we find ways of sharing meaningful data and insights in forms and in tools that actually support decision making. And we heard a little bit about what the UK is doing with some of that in the prior presentation to really help people actually have access to informatics and different ways of looking at things that will give them better information to help them make decisions. Principle 2, and again, keep in mind, these were built upon the ideas that were coming out of an ethics advisory board, and we were really informed by trying to ensure that we were honoring the ethical principles involved in research and care and in discovery and clinical decision making. So respect and empower individual choice. I mean, I think the idea that each of us is an autonomous being and we have the opportunity oftentimes to make our own personal decisions. When it comes to healthcare, sometimes that can be really challenging. But also, I think important is sometimes we have almost a forced autonomy on patients and say, it's your decision. You have to make this decision. When in fact, they need that decision made in the context of the relationships that support them. And that, for the most part, for most people, might be their family or friends. But oftentimes it is also the clinician who's sitting with them trying to help them understand what the next steps might be. So I think keeping in mind that throughout the course of the breadcrumbs that go from having the original research, for example, that might become part of a knowledge object, ensuring that the information was gathered in ways that actually did respect and empower individual choice, and that we don't lose sight of the fact that the knowledge object itself is just one piece of it, that it has to go back to the source and ensure that we've actually honored this along the way. The same with this. Principle 3 is informed, but understood consent. I think we all believe in informed consent and we all have processes to do that, but it goes much more beyond just being a signed form. There are ways where we today can do adaptive processes in understanding whether or not someone actually did take in the information and could essentially understand what they were agreeing to. So it goes beyond just sort of suggesting that we've got the consent of the patient, but it says not only do we have the consent of the patient, but the patient understood what they were going to be participating in, and that that participation could ultimately lead to knowledge that could become part of a computerized and digitized knowledge object, which I think is a really new concept for patients to begin thinking about, and the public in general. The fourth principle is people first governance. And this idea is pretty broad, but I think what it does is it suggests that we must put people first. We have to prioritize authenticity, transparency, and accountability, that we look back at who was involved in the research that we are going to be now putting into a computable form, and have they actually, will they benefit as a result? And I think Michael spoke to this, and being able to get information back as a result of participating in things like clinical trials and that sort of thing. So again, I think it's just critical. We oftentimes think about, the governance aspect of anything we do as having accountability to the entity we're working in or the institution we're a part of. But if we all believe that it's people first, we actually do shift our thinking quite a bit, and it really prioritizes how we think. I think Michael mentioned this, and I thought it was great where, we were talking about breaking through misinformation. So open communication and accountability has many cultural nuances to it. We have to really be sure that we're giving the information back in a way that's actionable for people in the languages that they can use, also in the culture and the environment within which they live in their community, so that it's accessible and actionable. The idea of being able to have some of this information and knowledge accessible in public libraries is critical. And that's an area where most people have a familiarity and communities actually are dedicated to. So I think finding ways for the MCBK community to make that connection for public and patients and people who are going to be needing this kind of knowledge, getting access to that in the most efficient and familiar ways, I think is an important piece. And then the last principle, it's almost as if in a way I feel a little embarrassed saying, oh, inclusivity, diversity, equity, it's so complex, it's so important. And it more than ever, I think in our times, this is something that's critically important for us to understand and unpack. It has to be practiced. We can't be preaching this. We have to step back and say, I'm not sure I understand what that means, and be able to be honest and humble about that. So I think we need to seek to understand diverse perspectives, all the while understanding that we, as in whatever culture you happen to come from, it may be new to you. It may be something you need to open yourself up to, even though you believed all the while that you've always wanted to include people. You've always emphasized the importance of diversity and equity, but maybe practicing that was a little challenging in the environment within which you were operating. So each of us taking that individual responsibility through the MCBK community, ensuring that these principles are absolutely at the forefront. And I'll end with a quote that I hope will provoke our thinking a little bit. For the most of us in healthcare, we've been on a voyage of ensuring that we're improving care, that we're trying to have patient centricity, that we're bringing people in at the table, as Michael said. But, sometimes the real voyage of understanding and discovery it's not in finding the new places that we have to go to or to seek new landscapes, as is said in this quote, but it's actually having new eyes, seeing things through a different lens, and understanding that if I flip my thinking about something, it actually opens me up to a whole broad arena of things that I hadn't previously really thought about. So I'm going to stop there. And again, thank you so much for having the opportunity to be here with you guys today, and looking forward to some questions.
Okay, well, I wanted to thank Sally and Michael, thank both of you for your incredible presentations and your obvious knowledge of this space, but even more important, your true passion for including patients and being, as Sally said, diversity, equity, inclusion really being practiced in every way, shape, and form, not just preached. So thank you both for that. We have had a number of good questions coming in, so let me sort through my they come to my email and then I ask them. So I have so many nice comments, but one is a question about patients versus patient advocates, and what do you see as the different roles and perspectives and approaches that MCBK might consider? I think that's the question for both panelists.
Mm-hmm. Michael, do you want to go first?
I'm going to refer that to you. I'll let you go first.
Okay, sure. I think it's interesting. I think oftentimes we don't necessarily always appreciate or understand the roles and responsibilities that a patient themselves can have within the relationship with their care providers. And so sometimes we immediately impose vulnerabilities on them that they don't necessarily have. So I think it is important to suggest that every patient actually can be their own advocate if appropriately empowered to do that. And when recognized that maybe they don't have all of the skills at that we actually help them find either a family member or somebody else that can help them be more of an advocate for themselves. So my view is that most anybody can be a patient advocate, but then the advocacy role itself, I think, shifts and then goes somewhat away from yourself and then to others. And that's where I'll defer to Michael.
And I want to piggyback on your comments too as well. I definitely agree with that. And that was one of the things that I was talking about, kind of like being an example and leading by example. It's not really, I guess, realistic to think that everybody might, have a video or a photo shoot or, be involved in some type of resource. But you have to kind of find what you're able to contribute, and there's just different roles in that. It could be something from like answering a questionnaire. It could be something as far as like going to an event in your city or taking part in a patient advocacy group. So there are different roles, and it's just a matter of finding that one that you feel most comfortable with and that you can be effective.
Mm-hmm. Good point.
That's all very thoughtful. There's probably more for Sally, but maybe you both can answer this. What opportunity is there to contribute to FDA initiatives to include patient and real-world data in the regulatory process of clinical trials? And can we train patients who want to contribute?
Oh, absolutely. The FDA has moved mountains in the last number of years in terms of thinking about the patient perspective, and whether that was in their patient-focused drug development work that was funded through the user fees, the PDUFA authorizations and legislation, which actually brought people with conditions into the FDA's building so that they could begin to learn what the experience of being a patient with these and what their treatment burdens and symptom burdens were like. But they also have a very robust patient action group. And also, whether it's on the drug side or the device side actually has now a patient engagement panel seated that actually provides counsel. So I think there's plenty of opportunities. And, there's certainly a lot of work that's been done in engaging patients across the full cycle of drug development, from the beginning of the design of the study through to the end to post-marketing and their experiences with the drug in the real life. So there's plenty of opportunities, I believe, where you could interject computable biomedical knowledge into what those experiences look like across that entire drug development process. And the FDA is most interested, especially in real world data that can lead to real world evidence. And we're really at the beginning of understanding how that can work. But COVID is actually a real test case for us to be able to take newly emerging knowledge, try to find its way from being data into evidence, and then put it into action. So I think there's a lot of opportunity.
Actually, it's great. I'll read a comment on that. That Brian Alper pointed out that an opportunity for MCBK related to COVID-19 research is active now through the COVID-19 Knowledge Accelerator at https://covid19_knowledge_accelerator.html. Anyway, so there are active working groups and bringing MCBK to this challenge. So I thought I'd point out that comment.
Josh, if you don't mind, I also would say that I'm part of the steering committee for the IMEDS program, which is part of the Reagan-Udall Foundation, and they have been working closely with the FDA, Friends of Cancer Research, to have these meetings each week. They have a lab meeting for evidence generation and acceleration, very similar idea. So there are these sorts of entities that are actively involved in COVID that actually are great petri dishes, really, for us to be working with and to find ways of taking that information that's getting generated and find ways of making it computable.
Mm-hmm. We have a question for Michael. I think the answer might be obvious, but for Michael, do you expect that your doctor is always informed by best evidence for all decisions, and how could MCBK help? I'm guessing I know the answer to the first one.
Wow. I think that they do the best that they can. And one good thing about it is now, and in all seriousness, I think that there has been a increase in the relationship between the health sciences librarians and being able to get research at the point of care and the point of need. And that's something that's extremely important in order to keep up with all of the changes that are going on. That's something that's like becoming more and more necessary. So I am pleased to hear that. And I would give them definitely props for that, both the librarians and the healthcare worker.
Yeah, I'll actually add to that point. There was a study at one point showing that, in the 1950s, biomedical knowledge doubled every 50 years. In 2020, it's expected to double every 73 days. And
oh, wow.
In
COVID, it's probably every 7 days.
In COVID, it's exploding. So I would just say, the ability of any human being to keep up with all knowledge in the field, no matter how brilliant and passionate and dedicated to doing the right thing that clinician or that person is, it becomes a team effort. And
absolutely. And that goes back to what I was talking about earlier. In order for healthcare to be successful, whatever, it has to be a team effort. It's not just the physician. It's not just the researcher. It's not just the patient. It's a combination of us all working together, gathering the information and experiences and putting them forth so we can make the necessary changes that we need to make going forward.
Okay. Another question is, do you see a place for MCBK in addressing patient safety issues by empowering patients to choose safe healthcare? Data about patient harm and hospital-acquired infections are typically concealed. And I'll just point out that, patient safety might be, depending on what happened with COVID, patient safety might be the third or fourth leading cause of mortality after heart disease and cancer, and possibly after COVID, but that's about it. And that's a scary proposition, and it's a number that hasn't budged as much as it could have in the years since the IOM report on the terror is human, which has been well over 17 years.
Exactly.
Well over 17.
Well, I'll respond to the question and defer to Michael as well. But I think indeed the opportunity to improve patient safety is always better harnessed when patients are informed. So when they know that there's something that isn't necessarily right, they're able to not only report that, but have that report be taken credibly, but also have that report be taken with accountability, so that you can see that something as a result of reporting on it would be effective. I agree that a lot of the experiences of adverse events and things like that happen in the institutional settings are oftentimes not brought forward or public. But I actually think in today's networked environments, patients actually have the opportunity to be able to bring this information forward. But I think, again, the important piece here is ensuring that even with patient-generated data about their safety or unsafe experiences, it will be important for us to find its, is the source of its legitimacy, is it credible, so that leads to trustworthiness, even when it's coming from the voices of patients themselves. We want to be sure that we're really advancing information that we can harness in an effective way, but also ensure that it's not misinformation. So I think there's a fine balance there, but I think it can be struck.
I would definitely agree with that. And I do think there's a lot of potential in that area. And to be honest with you, that's not really something that I ever considered, but I'm definitely going to bring that back to the groups that I'm involved in. So thank you for that question. That was great.
Continuously sharing knowledge there, right?
Absolutely. That's what we're here for. That's right.
Okay. So I guess, in closing, what are your thoughts on how we can sort of communicate this idea to patients and to broader communities and get them involved? And that'll actually lead into work groups where one of them is actually charged with doing some of that. So I would be curious to hear what your sort of final thoughts are on this before we turn back.
Well, having conferences like this, I think, are extremely important. And to be honest with you, I wasn't that familiar with it before. There was, and I must send a shout out to my colleague. He's a librarian, Jerry Perry, who actually connected me with Rachel and the rest of the team. So I really appreciate him. But just having organizations like this and just making them, it's not a good thing that we're in a pandemic. Don't misquote me or misunderstand me, but it really is good that there was this format to be able to do it in, because I think that a lot of people are being reached, and this information could really, really be disseminated far and wide and vast. And I think that some of the ideas and the talks that came from this particular conference or whatever are going to be able to be shared exponentially, actually. So I think I'm really, really excited about it. And it actually makes me want to do more research about this particular topic myself. So.
Yeah, I think, I've been around Chuck and Josh now for many years. And interestingly enough, even in Alan Green, and even as long as I've been around them, the notion of MCBK has always sort of stopped me in my tracks a bit to say, okay, what is it? It's so complex that I really want to break it down and understand what it means, not only to me, but to people that I might work with. So I think there's still work to be done. But here's my advice, and it would be to look towards the end use, and the end use with the public and patient in mind, and then work back to say, okay, well, if they're going to be the end user of some of this knowledge that we have gathered, what is it that we're going to need to be thinking about we can, integrate into the strategies for implementation and dissemination and cultural nuance, as well as, ensuring that it's reaching into the communities where it will matter. I think you have to start there and then work your way back and think about, okay, where can we begin now in order to ensure that the end user of a patient, or more broadly, the public, benefit and can have actionable ideas on what to do next with this. And so that would be how I would leave it, I guess.
I mean, years ago, Josh Seidman at the Center for Information Therapy put forward this idea that you're just like prescribing a pill. Knowledge has to get to the right person in the right time, in the right form, at the right dose, for the right reason, with the right, whatever you want to call it, with the right metadata about that knowledge. Very much like prescribing drugs. You need to prescribe information in the same way and get it where it needs to go, when it needs to go there. And MCBK is, very much all about that. And I thank both of you for sharing your perspective on how to bring patients and really diverse stakeholders into the movement, without whom this movement will not get anywhere. So I'm now going to turn it back over to Rachel, who's going to let us know what the afternoon's going to hold. So again, thank you, panelists. Thank you, everyone. Thank you for the great questions. There are more questions that weren't answered that I guess we'll figure out how to get them to Sally and Michael, and we'll get responses to them. But now it's back to Rachel. Thank everybody.
Thank you.
Thank you.
All right. Wonderful. Thanks again so much. I just want to echo Josh's great remarks. This was just a terrific session. And Michael and Sally, thank you so much for bringing in perspectives that haven't really made it into our larger community yet. So this was just thrilling. And I'm glad you could join us. And Josh, you did a great job moderating that. I know we'll just continue to collect and curate and address these questions and suggestions as we move forward. So I will stop so everyone can have their quick break. And in the next few minutes, work your way into the workout action sessions. And then we'll see you back here at closing session at 3:30. Thank you.